adjuvant and neoadjuvant therapy. So once again, I'm Roda Amaria. I'm one of the melanoma medical oncologists. So in order to kind of really dive into this talk, we have to have some definitions. So adjuvant therapy just basically means giving additional cancer treatment after surgery is complete. So if Dr. Gershenwald or Dr. Wargo feels like a patient's cancer is significantly worrisome, that there's a risk of recurrence, they'll send them to me as a medical oncologist to talk about adjuvant therapy after the surgery is complete. The idea here is that if there's microscopic deposits of melanoma floating around in a patient after the surgery that we can't really see on a CAT scan or a PET scan, the idea is to try to give some therapy to try to destroy that disease so that the melanoma never comes back. This is a little bit different than neoadjuvant therapy, which is a treatment that we give as a first step if a patient has a large deposit of melanoma, either in the lymph nodes or deposits of melanoma that have popped up on the skin. And so the idea here is that if we give therapy up front, we can potentially shrink down the tumors to make the surgery less invasive. And again, we're trying to also potentially destroy any microscopic deposits of melanoma in the bloodstream to prevent the cancer from coming back at a future time. So if we talk a little bit more about this adjuvant therapy, so this is, again, treatment that we give after surgery is complete if we think your risk of melanoma coming back is relatively significant. And so an ideal adjuvant therapy has to be effective in destroying those microscopic deposits. And of course, we want this to be a pretty easily manageable medication regimen in terms of toxicity, because not every single patient that has melanoma in the lymph nodes, for example, is going to have their melanoma come back. So if we give an adjuvant therapy and we give a lot of side effects, we potentially are harming a patient by giving those side effects when their melanoma may never have come back anyways. And so if we look at FDA-approved medical adjuvant therapy, there's really two medicines. They're called interferon alpha and pegylated interferon. And so basically, in order to understand these medicines, we have to understand that their job is to stimulate the activity of the immune system. And we're going to hear a little bit more about immunotherapies in detail from Dr. Hu, but basically this is a gray cancer cell that's being recognized and engulfed and hopefully eaten by these three green cells, which are called T-cells. And I think of T-cells as really the soldiers of our immune system that are there to keep us safe from threats. The vast majority of threats we come in contact with are bacteria and viruses and those sorts of things. But what's so cool about these T cells is you can actually train them to recognize a cancer like melanoma and destroy them. And that's what interferon and pegylated interferon try to do. They try to make this army of T cell soldiers. The trouble with these medicines is that it's not necessarily easy to take these medicines. So if we look at interferon alpha, this is an older drug. It was approved in 1996. And we can use it for people that have thick primary melanomas without lymph nodes, or for people that did have lymph nodes involved. The way that it's given is a little cumbersome. You have to come in for a month and get an IV infusion for about, I think, an hour or so. Then after that, you get a subcutaneous injection, a shot that you learn how to give yourself 3 times a week for 11 months. Basically, all patients will have some degree of toxicity, which is usually basically feels like you have the flu-like toxicity. And the benefit is controversial because if you look at all the clinical trials that have been done, it really looks like it delays relapse, delays the onset of relapse in about 10% of patients. There was an initial study that showed that people that got the interferon lived longer than if they got a placebo, but that was only in one initial trial, and those results have not been confirmed with additional trials. Then there's a newer drug called pegylated interferon, which is basically a similar version of interferon, but it's got a molecule attached to it so that you only have to give it as a shot once a week. This is much better tolerated than interferon alpha, but again, the data is somewhat poor in my mind and only seems to delay relapse by about 9 months, but doesn't necessarily make patients live any longer. And so this isn't great, and so we've looked for other things along the way. And so this was a clinical trial that was reported in 2014 with a regimen called biochemotherapy, which is a very complicated regimen, basically made up of 5 different drugs. And it has to be given in the hospital because it's complicated and associated with a lot of side effects. So this was a trial that was done where patients that had stage 3B or 3C melanoma, so patients that had potentially 30 to 40 to 50% chance of their melanoma coming back because of the amount of melanoma in their lymph nodes, they were randomized, they were screened for this trial and then enrolled, and then half the patients got interferon and half the patients got biochemotherapy. What we found is that the patients that got interferon, if their disease was going to come back, it came back on average at 1.9 years. If they got biochemotherapy, it came back on average at 4 years, so more than double the time at which the cancer came back. However, there's some significant toxicities associated with the biochemotherapy, so we'd expect more side effects in the biochemotherapy patients than the interferon patients. And the other big kicker is that, again, patients that got the biochemotherapy, even though they're relapsing later, they're not necessarily living any longer. So a lot of people look at this data and say, why should I give a very potentially side effect rich regimen to patients if they're not necessarily going to live any longer? And that's a very valid concern, but again, something that I will sometimes do in patients that have fairly high risk disease and fairly high risk of recurrence. We clearly need to do better, and that's why we do clinical trials. And a lot of clinical trials that have been done for adjuvant therapy have included vaccines. And vaccines are a good idea. The whole idea is to try to introduce your immune system to what melanoma looks like, so that if a T cell is cruising around and bumps into a melanoma cell, it says, oh, that's melanoma, and it destroys it. That's the idea behind these vaccines. And vaccines in general, I think, are a good idea. They're not terribly toxic. They're well tolerated. But the issue is we haven't really hit a home run in terms of getting a very effective vaccine for melanoma yet, and that's why there's none that are FDA approved, but certainly we keep trying with these vaccine trials. And then what I think is also very exciting is using newer immunotherapy agents called checkpoint blockers that Dr. Hu will talk about later on in the course of the conference today. But a couple of these drugs are ipilimumab, and I'll show you some of the data with that, and then there's some upcoming trials with anti-PD-1 antibodies. And so this was a clinical trial that was run predominantly in Europe, where basically patients that had surgically removed stage 3 melanoma were randomized to either receive placebo or ipilimumab at a higher dose than we usually use here in the US. And what this showed is that patients that got placebo, they relapsed on average at 17 months, and if they had the ipilimumab, they relapsed on average at 26 months. But there was significant toxicity associated with the ipilimumab in comparison to the patients that got the placebo. And again, the overall survival is not any better. And so this is a little bit of a controversial trial, especially in the US, because we don't like to give this high dose of the ipilimumab. And it's not necessarily fair to compare ipi versus a placebo. We would want to try to compare to our standard of care. And that's what this trial was. This was a trial, similar patient population. One group of patients got interferon. One group of patients got ipi at the low dose, and one group got ipi at the high dose. And what actually happened in this trial is that, again, there was significant toxicity associated with people who got the high dose of the ipi, so this arm was actually closed and really went on to fill the trial with patients in these two groups. And so we're anxiously awaiting the data, and it's not yet available. I think the trial is just recently closed, and so we're waiting to see if the ipi at the lower dose is going to be helpful in improving time of relapse and overall survival as well. Now, there are plenty of patients out here in the room that have what are called BRAF mutations in their melanoma, and Dr. Davis is going to talk to you a little bit about this in a few minutes. But this was another trial that was done for people that had BRAF mutated melanoma, again, surgically removed melanoma in the lymph nodes. And so one group of patients got 2 drugs to try to target the BRAF mutation specifically, and one group of patients got a placebo. That trial is closed. We're awaiting the results on that to see if using the adjuvant targeted therapy is going to be useful in this patient population. And so that's really the landscape that we have for adjuvant therapy in melanoma. So I'm going to switch gears and talk a little bit about neoadjuvant therapy. And just to remind you, it's therapy that we give up front. If you have a big lymph node or a big deposit of melanoma on the skin, we give the therapy up front, then we do the surgery. And that's really what the paradigm for neoadjuvant therapy. So what we're ideally looking for in neoadjuvant therapy is, again, treatment that's available to shrink down tumors rapidly, has to have an easily manageable or predictable side effect profile. And what's really cool about neoadjuvant therapy is because the tumor is in play, we can often do biopsies of the tumor over the course of therapy to try to understand why this person is having an excellent response to therapy or perhaps a suboptimal response to therapy. So it really allows a lot of scientific understanding of what's happening in the actual tumor if the tumor is in place while you're giving the treatment. And so this is an example of a patient I treated, a 60-year-old man who presented to me with a large melanoma in his sinus. This was his left sinus here, and this was a mass. This is what it looked like if you're kind of looking down. This is what it looked like looking towards the side. And it's basically a 4-centimeter mass of melanoma back here in his sinus. I gave him 4 cycles of biochemotherapy, and it worked great. It really shrunk his tumor down. It looks like there was still a significant residual amount of tumor after I treated him with 4 cycles. He went on to have surgery, but what was super exciting about this is that when the surgeon went in to take the tumor out, all the tumor was dead. Even though this mass was still there, it was all necrotic, dead, scarred down melanoma. There's actually no viable melanoma. And so this is what we call a pathologic complete response. And this shows that this patient had an amazing response to therapy. He had his surgery. He had some radiation afterwards. He's doing great. And I just saw him a couple months ago. This is another patient that we're actually treating on a clinical trial. She's not here today, but again, a patient I just saw a couple days ago in clinic. She had presented to us with lymph nodes in her underarm that you could feel, you could palpate them. She had found them. And she got 8 weeks of, again, dabrafenib and trametinib, which Dr. Davis will talk to you about. And these lymph nodes here, this was about a 2-centimeter, this is another 2-centimeter lymph node. After 8 weeks of treatment, really shrunk down. And again, when we did her surgery, it was basically all necrotic. There was no active, viable melanoma at the time of her surgery. So because we're really interested in clinical trials and because we're really interested in neoadjuvant therapy, Dr. Wargo and I and our teams have designed a couple of clinical trials. One is that trial using the BRAF-MEK, and another trial is using the new checkpoint blockers for patients with this, big lymph nodes or what we call couples deposits of melanoma in their body. And so these are the clinical trials that we're running, and Dr. Wargo might talk to you a little bit more about this later on in the talk. So just to wrap this up, to try to stay on time, we know that there are FDA-approved adjuvant therapies for melanoma, including interferon alpha and pegylated interferon. Use of these agents is somewhat controversial due to significant side effects and data that only supports delay in the onset of relapse. We definitely need to be doing more clinical trials. There are some that have been done, and we're awaiting data to see if we've changed the standard of care for patients with for adjuvant therapy for our stage 3 patients. And more we're trying to look into the power of neoadjuvant therapy for patients with high-risk melanoma, again, to try to shrink down disease and to prevent disease recurrence. And we have a couple of clinical trials that we're accruing here at MD Anderson to try to change the standard of care for these patients. And that's it. Thank you very much.